And then it is my pleasure to invite the next speaker, Dr. Hasitha Wijewantha. He's a gastroenterologist from Teaching Hospital Ratnapura. Hasitha, over to you. Please take over. Thank you very much.
First, I will discuss about the name change and the circumstances which led to it, because it's a current topic and the heated debate in the field of gastroenterology, and followed by, after that, I will discuss optimizing management for maximum benefit in non-alcoholic fatty liver disease. This disease was first described by the famous American hepatologist and physician Gerald Clatstein. It was presented in annual meeting of the American Association of Study of the Liver in 1979. Subsequently, this name of non-alcoholic steatohepatitis was given by Ludwig and colleagues in his publication in Mayo Clinic Proceedings. So, what is non-alcoholic fatty liver disease? It's presence of steatosis in more than 5% of hepatocytes in the absence of significant alcohol intake and in the absence of no other non-liver diseases. So there are two categories: non-alcoholic fatty liver disease when there is no evidence of hepatocyte injury or inflammation, and non-alcoholic steatohepatitis, it is a histological diagnosis when there is more than 5% steatosis with inflammation, hepatocellular injury with or without fibrosis. So key features are absence of unsafe alcohol consumption, absence of other competing etiologies for hepatic steatosis such as drugs, etc. No other coexisting liver diseases, and it is divided into two main entities: steatosis with inflammation and steatosis without cellular injury or inflammation. That is called MAFLD and Nash. So because of the deficiencies in this definition, the name, there was an urge, especially in the Western hepatologists, to change this name from the early 2000s. And as a result, in 2020, these worldwide experts came up with this paper with the suggestion and proposal to change the name from non-alcoholic fatty liver disease to metabolic associated fatty liver disease. Subsequently, name was slightly modified to metabolic dysfunction associated fatty liver disease. So what is metabolic dysfunction associated fatty liver disease? That means hepatic steatosis diagnosis by imaging techniques, blood biomarkers or scores, or by histology in a patient who is overweight or has diabetes. When the patient does not have obesity or diabetes, then he or she should have components of metabolic syndrome. So in short, the steatosis in a patient who either have obesity, metabolic syndrome, or diabetes mellitus. So what are the components of metabolic syndromes? Waist circumference, blood pressure, plasma triglycerides, low HDL, pre-diabetes or impaired glucose tolerance, insulin resistance, and systemic inflammation as evidenced by high sensitivity CRP level more than 2 milligrams per liter. So these are now this slide shows the differences between MAFLD and NAFLD. As I discussed earlier, NAFLD is basically a diagnosis of exclusion of alcohol intake or other competing etiologies. So no requirement for metabolic dysfunction, and it cannot, as per its definition, it cannot coexist with other liver diseases. So liver biopsy is required for diagnosis of Nash. It's one of the main deficiencies in this name and the definition. So what about metabolic associated fatty liver disease or metabolic dysfunction associated fatty liver disease? The inclusion criteria includes overweight or obesity, type 2 diabetes mellitus, metabolic dysfunction, and most importantly, it can coexist with other chronic liver diseases such as hepatitis B, hepatitis C, alcohol, and autoimmune hepatitis. So independent from alcohol intake, and no requirement for liver biopsy. It's a spectrum of disease, and disease severity would depend on from stage to age, and there is no dichotomous entities such as non-alcoholic fatty liver and fatty liver steatohepatitis. But so fatty liver fat deposition in liver and fat deposition and inflammation in the liver is multifactorial. Not only metabolic syndrome, it is affected. The etiological factors are insulin resistance, genetic factors such as PNPLA3, bile acids, gut dysbiosis, circadian clock, environmental stresses, and so many other things which we even don't know yet. So And also, as you can see in this cartoon, when the classic metabolic syndrome is only one factor which contributes to fat in the liver, and lipodystrophy, infections, xenobiotics such as tetracycline, malnutrition, chronic inflammation, defective metabolism like in Reye's syndrome, trans-antacid excess, all those things can cause fatty liver disease. So after the invent of this new term MAFLD, now people with fat in the liver were divided into three groups. First category is non-alcoholic fatty liver disease, which do not qualify criteria to be diagnosed as MAFLD. Second category, the overlap group. The third category is the people who qualify the criteria for metabolic dysfunction associated fatty liver disease and who do not have fulfilled the criteria of NAFLD. So now, after some time, even some of the authors of the original paper and consensus document realized that this name has so many, now name suggestion, even the name suggestion has so many deficiencies. So now this is the second paper from MAFLD to MAFLD, the implications of premature change in terminology. 8 out of the 4 authors in this document are authors of the first consensus document as well. So now, so then they changed, they came up with this paper and with their comments that now there are so many negative, features in the new terminology MAFLD as well. To sum up what we have discussed so far, there are still significant gaps in knowledge on diagnosis, natural history, and treatment. MAFLD is a heterogeneous condition. We may never be able to assign a single name for a disease as heterogeneous as MAFLD. Name change is not based on new knowledge on pathogenesis, risk stratification, molecular phenotyping, or therapeutic approaches. So, however, as the debate goes on, just like anything else in this world, the balance is tipped towards eminence rather than evidence. So, finally, to conclude, now non-alcoholic fatty liver disease has so many deficiencies. It's a diagnosis of exclusion, and it has so many emphasis on alcohol, which is sometimes not true. However, the NIM terminology, metabolic dysfunction associated fatty liver disease, also has so many inefficiencies. Insufficiencies. So MAFLD is yet another inadequate terminology which needs to be redefined as we improve our understanding of the condition. So I will keep on the term old name. I will discuss this condition here from now onwards as non-alcoholic fatty liver disease. So what are the outcomes of non-alcoholic fatty liver disease? Increased overall mortality. It is the commonest cause of death in patients with non-alcoholic fatty liver disease is cardiovascular. Higher incidence of liver-related outcomes. Third commonest cause for hepatocellular carcinoma. Increased incidence of non-liver cancers. Coexisting diabetes increases the prevalence of Nash and advanced fibrosis. Presence of increasing number of components of metabolic syndrome increases the incidence of advanced fibrosis. And most importantly, 11% of incidentally discovered patients with fatty liver may be at risk of advanced fibrosis even at the time of finding, according to NAFLD fibrosis score. So fibrosis is one of the main determinants of mortality in patients with non-alcoholic fatty liver disease. It affects all-cause mortality and liver-related mortality also. As the fibrosis stage advances, mortality also goes up. So how do we detect fibrosis? Now, Mananjala discussed this in detail. These are the serum markers. These are transient elastography. It's an ultrasonic-based physical investigation. So out of these serum markers, FIB4 index and NAFLD fibrosis score has been found to be better in predicting early fibrosis in patients with non-alcoholic fatty liver disease. So FIB4 calculators are available as apps and even in your smartphone. In fact, this is a screenshot of my phone. And if you fill these cages, your app and phone will automatically calculate the FIB4 value. So if the FIB4 value is less than 1.45, it's unlikely to have advanced fibrosis. And if the value is more than 3.25, are likely to have advanced fibrosis. In between, patients needs further investigation. Other indirect markers of advanced fibrosis: AST more than ALT, thrombocytopenia, splenomegaly on ultrasound scan of a patient with non-alcoholic fatty liver disease. Fibrox scanned evidence of advanced fibrosis. However, it's not freely available in the periphery, and even in Colombo, only few centers have FibroScan. As Mananjala explained, the liver stiffness measurement more than 10 confirm implies that there is advanced excludes less than 10 excludes advanced fibrosis, more than 50 confirms advanced fibrosis. However, as you can see, even at values around 7, there can be F1 fibrosis. So Mananjala discussed advanced fibrosis. Now what I am talking about here, F1 early fibrosis. So even at liver stiffness level of 7, you can have F1 fibrosis. So when to do liver biopsy? To rule out competing etiologies, when assessment of underlying liver disease is not possible without a biopsy. It is very important these biopsies are interpreted by a pathologist who has a special interest in liver histology. So goals of liver biopsy: to confirm or exclude the diagnosis and assess the severity of the disease, whether it is non-alcoholic fatty liver or whether it is non-alcoholic fatty liver with some degree of inflammation, and whether it is full-blown non-alcoholic steatohepatitis. To stage the disease, staging means that to objectively assess the degree of fibrosis, and grading means to assess the objective assessment of the necroinflammation. So NAFLD therapy. So treatment of NAFLD involves treating the underlying liver disease as well as associated comorbidities. As most of you all would have seen, non-alcoholic fatty liver disease that does not exist on its own. It is most of the time it is associated with other comorbidities. So promote weight loss by diet and exercise, control of main cardiometabolic risk factors, correction of modifiable risk factors associated with progression of NAFLD, prevention of hepatic and extrahepatic manifestations, avoid and prevent other potential causes of hepatocyte injury. In our setting, commonest cause is hepatitis A, and we don't have hepatitis B that much. So anyway, when you diagnose a patient with fatty liver disease and who is at risk of further fibrosis, it's always a good practice to offer them hepatitis A and B vaccination and avoid hepatotoxic medication. Especially ask the patient, do not take herbal medicine and herbal drinks, especially collagen. So what is the preferred diet in non-alcoholic fatty liver disease? Mediterranean diet has the highest evidence in non-alcoholic fatty liver disease. It's a low cholesterol, saturated fat, low cholesterol and low saturated fat diet, high monounsaturated and polyunsaturated fatty acids, and higher content of omega-3 fatty acids and low omega-3 6 to omega-3 ratio, moderate amount of fish and white meats. So reduction of calorie intake by 750 to 1000 kilocalories per day results in improvement of insulin resistance and fatty liver. And unsweetened coffee may have beneficial effects. Refined sugar and high fructose corn syrup should be avoided. And most importantly, alcohol should be avoided. There is no safe limit. New evidence suggests alcohol has a synergistic detrimental effect on the liver along with metabolic syndrome. Alcohol is likely to have a dose response effect rather than a J-shaped association as previously we thought. So the other thing is now excessive fructose consumption can lead to addictive behavior. Now, ladies and gentlemen, be watchful to see whether your children are fructoholics. If it can cause addiction and ultimately can lead to fructoholic liver disease, just like alcoholic liver disease, especially in children. So weight loss. So weight loss of more than 5% improves steatosis. Weight loss of more than 7% improves NAFLD activity score. And weight loss of more than 10% improves all components of non-alcoholic steatohepatitis, including portal inflammation and fibrosis. So our target should be to advise our patient to lose more than 10% of their baseline body weight with diet and exercise and lifestyle modification. So what are the benefits of exercise in non-alcoholic fatty liver disease? Physical activity reduces the risk of type 2 diabetes mellitus, insulin resistance, hypertension, dyslipidemia, impaired fasting glucose, and metabolic syndrome. And this trial, published in Hepatology way back in 2009, had shown that irrespective of the degree of weight loss, people who engaged in physical activity more than 150 minutes per week, and those who increase their physical activity from the baseline by more than 60 minutes per week had improved liver functions, improved serum ferritin, and improved all metabolic variables except 2-hour postprandial blood sugar levels after 3 months. So exercise is beneficial irrespective of the weight loss in non-alcoholic fatty liver disease. Now, now I'll move on to the pharmacotherapy. This is a slide. This is a table from famous Pivens trial about the effect of Pioglitazone and vitamin E on Nash patients. As it, most of you all would know, it only vitamin E is the primary outcome. However, both vitamin E and Pioglitazone reduce hepatocyte ballooning, lobular inflammation, and steatosis. Both agents did not reduce fibrosis. Both agents improved AST and ALT level. In the Pioglitazone group, there were a significant increase in weight. It's one of the main disadvantages of Pioglitazone: fluid retention, osteoporosis, and weight gain. Those are the disadvantages of Pioglitazone. And vitamin E, there was not much of improvement in insulin resistance. So now Pioglitazone improves liver histology in biopsy-proven Nash in patients with and without diabetes. Now this study was conducted in non-diabetic patients. As you can see, it reduces, now negative value means improvement, positive value means increased. So the Pioglitazone has improved steatosis, lobular inflammation, liver injury, and fibrosis when compared to placebo. So as Mananjal has already discussed the importance of statins in portal hypertension. Statins has been shown to be beneficial in non-alcoholic fatty liver disease as well. Statins decrease the risk of non-alcoholic fatty liver disease and the risk of liver fibrosis once non-alcoholic fatty liver disease. It is the result of this, one of the major landmark studies involving more than 11 million people of South Korea. It was published in American Journal of Gastroenterology. And statin use was protective for full spectrum of liver damage in individuals at risk of Nash. However, certain genetic variants like PNPLA3 risk variants limited this beneficial effect. This again proves that it's not only the metabolic syndrome and the fat deposition and degree of inflammation. There are certain genetic variants which could influence the response to therapy and progression. So these are some of the new agents and anti-diabetic agents which have been shown to be beneficial in the management of non-alcoholic fatty liver disease. GLP-1 receptor agonists, liraglutide and semaglutide, it has been shown to show Nash resolution. However, not shown any effect in reducing fibrosis. SGLT inhibitors, empagliflozin is the drug which is available in Sri Lanka. It has shown to improve liver profile. And FXR agonist, obeticholic acid, is one of the new drugs which is in the development and hopefully soon will be available in the market to be used in MAFLD patients. And it has been shown to improve inflammation as well as fibrosis as well as and the liver functions. One of the main disadvantages of obeticholic acid is the elevation of low density lipoprotein level, LDL cholesterol, which is one of the major cardiovascular risk factor. However, now trials are being conducted in combination with statins and obeticholic acid, and also newer generation synthetic obeticholic acid derivatives, FXR agonists, are being studied, which do not have LDL raising effects. So bariatric surgery in non-alcoholic fatty liver disease, there are no randomized control trials on bariatric surgery in Nash. It reduces weight and improves insulin sensitivity, diabetes, hypertension, dyslipidemia, and obstructive sleep apnea. Some studies have shown biopsy confirmed resolution of Nash and fibrosis. However, it is still not recognized as an established specific treatment method for Nash. And at present, bariatric surgery is only indicated in patients with Nash who are otherwise eligible for bariatric surgery. So finally, when to refer for specialist care? Presence of multiple components of metabolic syndrome, as I explained to you all earlier, it is a risk factor for advanced fibrosis. and abnormal liver biochemistry. Most of the time, non-alcoholic fatty liver disease patients do not have high non-alcoholic fatty liver without inflammation do not give rise to high transaminases. So if the patient has transaminases more than 2 times the upper limit of normal, or any evidence of cholestasis, high bilirubin or alkaline phosphatase, should be able. Patient should be referred to a specialist. Suspicion of advanced fibrosis, appearance of ankle edema is the commonest presenting complaint of our NAFLD patients with cirrhosis. So be watchful when you see a patient with non-alcoholic fatty liver disease patient for the signs of chronic liver disease. And thrombocytopenia, AST more than ALT, splenomegaly on ultrasonography. FIB4 score, as I explained to you all earlier, it can be easily calculated. If the score is more than 1.25, please refer the patient for specialist care. And evidence of coexisting liver disease, transaminases more than 5 times the upper limit of normal. Even though patient have non-alcoholic fatty liver on ultrasonography, if transaminases are more than 5 times the upper limit of normal, it is unlikely to be, it is due to steatohepatitis. So please refer the patient to a specialist care. Clinical jaundice or high bilirubin, high globulin or elevated inflammatory markers suggest an autoimmune etiology. Positive autoantibodies, positive viral markers, serum ferritin more than 1.5 times the upper limit of normal with high transferrin saturation, history of hepatotoxic drugs or herbal medicine use, and problematic alcohol use. All these are indications for specialist care. So this flow chart is the guidance given by the European Association for Study of the Liver. Now, when the patient has metabolic risk factors, ultrasound scan should be conducted. If there is steatosis, do liver functions and calculate FIB4 score. If the patient is low risk, then you can follow the patient up again in 2 years. If there is in between, between 1.25 and 3.45, the specialist referral. Anyway, if there is high risk, needs to be referred to a specialist. And steatosis is absent, then normal liver enzymes follow up in 3 to 5 years. Steatosis is absent, however, patient has abnormal liver enzymes, then again needs specialist attention to this patient. So now these patients can be further evaluated with non-invasive markers, liver biopsy, and further serological markers. So that is the flow chart given by the European Association of Study of the Liver. Thank you very much.
Thank you very much, Dr. Hasitha. Just wait till I on my video. Thank you very much. I'm very grateful for that very informative talk. There is one question. Give me a second. I will put that to you. First question is, what is the dose and duration of vitamin E therapy?
So the trial that I discussed here was Piven's trial. The dose that was used was 800 international units daily, and there was no specific duration mentioned. And the trial was conducted, I think it's for about duration of 3 years. Now there have been certain concerns about the safety of the vitamin E, but it has not been substantiated by subsequent studies. So the dose is 800 international units daily. It can be given as 400 international units twice daily or twice daily. So dose is 800. And I can see the other question as well.
All right, okay. If you get that announced, that will be very good. Yes.
Yes. So fish oil, omega-3 fatty acids. I mean, that is what is meant by fish oil, I suppose. So fish oil, omega-3 fatty acids has some benefits in cardiovascular diseases and in patients with dyslipidemia, but it has not shown any benefit in non-alcoholic fatty liver disease, and it is not recommended in guidelines. And the other question is metformin. Metformin improves insulin sensitivity and it improves liver profile. However, it has not been effective in improving any components of the non-alcoholic steatohepatitis or improve fibrosis. So only for NAFLD, metformin is not recommended. However, in a patient with metabolic syndrome and diabetes, metformin is very beneficial. And there's another question I can see. What is the place for Hepacol and Oblivia? I would say no. I don't know what is Oblivia even. Hepacol is a, is a vitamin supplement, and it is basically commercial use. So there is no scientific evidence.
Yeah, and then we will move on to the next talk. May I present you your certification of a